because you manage the chest tubes. And there are some medico-legal implications of your involvement in the part as a team. Now, this is a method whereby the surgeon has made an incision, making a track, and then going into the chest wall. There you see this man, after having gone through the chest wall, is going with his finger. That is the open method, because your fingers are blunt and sensitive. So once you put your finger through that hole, then you can feel if there is something in front of it or not. Okay? And you can brush that aside. And then you put in the chest tube. Using the word inserting the chest tube implies a forceful maneuver, inserting the chest tube, rather than putting the chest tube in with an open method. That is the only recommended safe method. Okay? So now coming back to the real world. You have had a patient diagnosed any condition, effusion, pneumothorax, and a decision has been made that a chest tube is to be put in. You are in a busy hospital, you work in shifts, you do not know everybody. Even if you know people, when a person comes in to do that intervention, it is one of the responsibility of the nurses to check the privileges of that person. And be bold. If you do not find the privilege for that particular physician to do that particular intervention on the patient, then you say, hold on, I will not let you do that until I get your senior. And you should all be confident enough to do that. There is absolutely no problem. When you do not do that, then you can end up in problems. Did you check the privilege of the person you allowed? And you can stop a doctor if you see that the doctor is not doing an open technique and is insisting on putting this iron rod with a tapering end at the end and is trying to push the chest tube with force inside. Said, hang on, dear doctor, do you realize what you're doing? That may be very unsafe. Okay? Now, I'll have a few slides about the bottles, the drains, and a couple about the chest tube itself. Now, all of you have seen all kinds of chest drainage bottles. Once you put in the tube, you cannot let it hanging in the air. You connect it to a drainage system, isn't it? So you must realize why you are using something and what is the advantage or disadvantage or necessity of using. Now, you have simple drainage systems, bottles, to very complex ones. As you can see, there are several of these in the hospital, and you see it all around. And have you ever wondered why this one is used, why not that one, why that one, why not this one? I'll tell you the principles on which. The very first bottle was like when you were doing chemistry in the school, you had this wolf's bottle, a bottle which has got two mouths in it. One goes down, this is water, one goes down into the water, the other stays up, this comes from the patient, so the liquid goes in, keeps collecting. If any air is coming out, the air will bubble out like you have in the smoking pipe, the hubbly-bubbly, shisha. And it will get out either into the air or you pull it with a suction. This is the simplest, most economical form and method of chest tube effluent drainage. And it works in almost all the situations. Now, like everything else in medicine, we play with toys. How many of you have invented any instrument which you are using? Has anybody made an instrument which you use all the time in the hospitals? Raise your hands. I don't see any. Exactly. We are treated like children. Somebody else makes the toys for us. We take it and we use it, like adults make toys for children. So you must understand on what principle that toy is made. So I told you that this is the simplest chest tube bottle, and that works. Then somebody said, what will happen if there is too much fluid coming up here? If there too much fluid comes up here, then it will not allow the air to come out. So that was a problem. This is largely theoretical. So they said, okay, why don't we attach another bottle so that all the liquid will collect here and the air will go in like the first bottle and it will come out. So now I can say, so I can visualize that a smart salesman telling his company boss, then we can sell 2 bottles for the price of 4 rather than 1 bottle for each patient. So we'll have 4 times the price, telling the doctors and nurses that this is better. So that's where the second 2-bottle system came. Then somebody came in and said, well, if you have only 2 bottles, then if you put suction here, maybe the regulator doesn't work nicely. Then it will pull the liquid in here. So why don't we have another one whereby you have the regulator and you apply suction. If suction is above your desired level, then the water will be pulled out from here or air will come in, so it will have a safety high limit. And now you have got 3 bottles for the price of 6. Okay? Then somebody said, that's very nice, but what happens if that system doesn't work? Then you have to have a safety valve. So it's okay, we add another 4th bottle in there. Now you've got 4-bottle system for the price of 15 bottles. And everybody missed the point. The suction, is it needed all the time or not? If I get a pneumothorax and you put in a chest tube in me and I can cough, that raises my pressure inside the pleura more than 40 centimeters of water. And all of you who have used suction, you know that you use suction for about 10, 15, maximum 20, 25 centimeters, not more than that. More than that will hurt, will be painful to the patient. So a person who is awake, who is coughing, usually does not require suction. A person who is sedated, unconscious, ventilated, yes, that person requires suction. So you must keep that in track. So for everybody, you do not have that suction-oriented, perfected, complex system. And those 3 and 4 bottles have been compressed by the companies, and this is what you see. Okay, so that fancy bottle which I showed you in the beginning is actually the same simplified 3 or 4 bottle system. You got it? So carry home message is, use the simplest one. If it doesn't work, then you think of the other one. Don't start with the most expensive. I'll tell you a simple price comparison. That the simplest one cost you about, say, 70 reals. And this complex one cost you about 700 reals. Disposable. So think about that. Let's talk about chest tubes. There are various sizes of chest tubes, and it all depends on what are you draining, what consistency, what type of air is. Everybody knows air has got one consistency, but liquids vary in consistency. Is it a runny fluid? Is it a thick fluid? Is it suppurative or not? And what is the magnitude? You can have a very high leak in a person, for example, who had a lung removed and the staple line on the main bronchus breaks up in post-operative period. So you can have everything coming out. And they usually come into this size, 8 to 36 French. And the French scale is if you multiply that number by 3, you will get the diameter in millimeters. Okay, so for example, 24 French is 7.2 millimeter and on. So multiply the French by 3. Now, what has started all this campaign and talk which we talked about is the issue, how do you do nursing management of a patient who has had a chest tube? A proper chest tube has been put in the proper place, by the proper method, by the proper doctor, and had a proper chest drainage system attached. Everybody feels happy that we have done a good job, and you go home. And you come back in the morning, or you hear that your patient has died all of a sudden, which has happened a year ago to 3 patients in this hospital. And there, is this a message? Okay. No, I'm just being told 10 minutes remaining. Fine. And that issue, one of the most serious issue, is the clamping. Like, there's one way. Either you understand this whole talk about why clamping is not a nice thing, or when it should be done, when it should not be done, or you have one very simple fact in your mind, that everything you do to your patient, you ask a physician order. Doctor, can I give water to this patient? I said, yeah, then you write it up. That's not nail by mouth, you give water. Can I give oxygen? Please write here. The basic elements of life, you need written orders, isn't it? For water and oxygen. For clamping the chest tube, nobody asks for a written order. The nurses somehow or the other are very happy, take out a metallic clamp and clamp it without taking a written order. So please don't do that. You must take, the exception only is an emergency. Now you see, all of you are familiar with this. can we take this patient down to X-ray or to operating room? I said, yes. You put a clamp and take the patient. Who had asked you to put the clamp? Nobody. You have done an action on your own, entirely indefensible. If you had a written instruction, the blame lies to somebody else. And I'll tell you how it can be of very serious consequences. If a person is having air leak and you put a clamp, what will happen to that air which was coming out? It will stay in. And you have just seen that it can produce a pneumothorax, and that can progress to a tension pneumothorax. And the person, you are transferring a patient with an intermittent monitoring system, for example, every 15-minute blood pressure, and you do not know the person is covered, a female patient who is covered from head to toe and being transferred, and you do not know that she has stopped pumping. There is inflow occlusion because of the high pressure inside the pleural cavity, and it takes only 5 minutes for the brain to die. So it could be lethal. There's another way of clamping this. You see, you recognize the uniform? Must be one of your friends. Okay? The reason they do that, they say, doctor, if I put it up, the water will go back into the patient. Isn't it? Where did you get this water from? Sterile water? Clean water? Tap water? Sterile water. Where did you get the bottle from? In a sterile packing. How did you put in the chest tube? In a sterile way. Whatever has come out from the patient's body. So theoretically, even if it goes back, will that be life-threatening? No. The second question is, does it go back? I will ask all of you that when you go next time and see a patient with chest tube and a bottle, take it in your hand, knowing carefully what you're doing, lift it up. Lift it up, and lift it up, and see whether the water goes back inside or not. It doesn't. It's a misnomer, except in one type of patient, an elderly emphysematous patient with COPD who is breathing like this. He's creating too much pressure swing inside his chest. And that person you can see from 10 meters because his liquid will be going up and down from the floor, touching the bed and coming back. Big swing. If that one you facilitate and lift up, yes, it may go a little bit. Okay? But nobody else. Now, this clamping you recognize, but do you recognize this clamping? This is a bottle, and this is the blue thingy, the little cap over it, as it comes into the bag. You remove that bag, isn't it? This cover over the small tube. Now, if you imagine that this is coming from the patient, the air is coming, bubbling under the water, where the air will escape from? You have blocked the hole. So it is equal to clamping. Now, the another method of clamping is that you have the patient here, the chest tube coming in there, a suction pipe is onto the other side, and suction pipe is going onto a meter which is shut off. So it's not pulling. So air comes in, bubbles in, or can it? And where would it go? Nowhere to go. So that is also clamping. Every week or 2 weeks, I find someone who is effectively clamped like this. If your suction meter is not working, then just keep it open from here. Do not clamp it. Do not close it, please. I hope I make myself clear. The other thing, just more from the physics.